So Dr. Singh is an assistant professor of medicine at the University of Michigan in Ann Arbor. His research interests include understanding the role of diet in the pathophysiology of disorders of the gut-brain axis and in developing novel, evidence-based dietary therapies for their management. He is currently supported by the K23 Career Development Award from the NIH and grants from IFFGD and MNORC. He is the author of more than 90 clinical and translational research articles and reviews, appearing in top-tier scientific journals, including Gastroenterology, the American Journal of Gastroenterology, Clinical Gastroenterology and Hepatology, and Alimentary Pharmacology and Therapeutics. It's really an honor to have him on with us today. And so without further ado, I'll pass it over to you, Dr. Singh.
Thanks, Jocelyn. Thanks for that kind introduction. I will start. So you guys can see the topic here. We have a lot of learning objectives, so I'll go right in. So these are learning objectives for the talk. Determine the who, when, how, and why while using the low FODMAP diet in IBS. To talk about other dietary therapies in IBS. Some of them are old, some of them are new, and talk about fiber and functional foods in IBS. So just going right in, IBS, you guys know, is a chronic GI disorder which is characterized by chronic recurrent abdominal pain, which is associated with abnormal bowel habits, right? And depending on what these abnormal bowel habits are, it can be classified as constipation predominant, diarrhea predominant. If you have both, then you are labeled as mixed IBS, right? Coming to therapies for IBS, there are generally of three types. The first is obviously the diet and nutritional management. And then there is medical management, which involves the, pharmacological treatments. And then there are behavioral management involving hypnosis, CBT, and so on, right? For the purpose of this talk, we'll focus mainly on dietary therapies. Some of the examples are on the right. And of course, a lot of time will be spent on low FODMAP diet, given that the data is strongest here. Right. So currently, and I guess a lot of, or most of you guys know about this, about low FODMAP. The current way of doing low FODMAP is a step-down approach where we start with phase 1, which is the restriction phase, where we reduce FODMAP intake of all 5 FODMAP groups: fructans, galacto-oligosaccharides, lactose, fructose, and polyols. So we reduce intake of all these 5 FODMAP groups for a period of about 2 to 8 weeks and replace them with suitable low FODMAP alternatives, ideally from the same food group. Then if the patient responds, you move on to the second phase called reintroduction, where the patient is challenged with one FODMAP subgroup at a time, and then they monitor their symptom response. Based on that, then they move on to the third phase, which is the long-term maintenance phase or personalization phase, where they restrict only the FODMAP groups they are sensitive to, but are able to reintroduce the FODMAP groups they're not sensitive to back in their diet, right? So this is how we currently practice low FODMAP in clinical practice in a nutshell. So going into the learning objectives, the first topic is why use low FODMAP, right? And the reason to use it obviously is because it works. This is a network meta-analysis from Alex Ford's group now about 3 years back, which basically compares all the dietary interventions in IBS indirectly. And as you can see on the figure here, the low FODMAP is in the top, or it ranks first compared to all other dietary interventions. And the green highlights that it is statistically superior to each of the other dietary interventions studied, that it is superior to a nice diet, superior to habitual diet, sham diet, high FODMAP diet, every other diet studied in terms of its improving global IBS symptoms, right? And I know the tables are hard to see here, but these are tables for individual IBS symptoms, pain and bloating, and same as global IBS symptoms, low FODMAP again ranks first here for both of these IBS symptoms and is superior to sham or nice diet for these symptoms as well. And one thing I would like to point out is that when you talk about individual IBS symptoms, right, the magnitude of improvement seems to be greatest for abdominal pain. That is the symptom which improves most with low FODMAP diet, and closely followed by bloating. And there obviously is this network meta-analysis and other studies from our groups and others have shown that there is no difference in efficacy of low FODMAP among various IBS subtypes, that it works equally well for constipation predominant, diarrhea predominant, and mixed IBS, right? So that's why we use it, because it works. And the next question obviously is when to use it, right? And of course, when not to. And and oftentimes, right, like we and gastroenterologists struggle with when should I pull the trigger for low FODMAP, right? Like, should it be first line? Should it be second line? Should it be third line? How to place it, right? And I think I want to walk you guys through two of these recent studies, which are very helpful to answer those questions. The first is from Jan Tak's group, published a couple of years back now, where about 460 primary care IBS patients, so these are patients not being seen by GI, but by their general physician, who were randomized to otilona bromide, which is an antispasmodic, or low FODMAP diet administered via an app. And their primary endpoint was a 50-point decrease in IBSS, which is pretty standard for all IBS trials. That is a responder definition, which most IBS trials would use. And then, as you can see on the figure on the right, as at both 4 weeks as well as 8 weeks, low FODMAP did better than this antispasmodic. And there was a 10% gain, meaning about 10 there was a 10% patient improvement, more patient response in low FODMAP group compared to the antispasmodic group. So this study concluded that in primary care IBS patients, low FODMAP was better than antispasmodic in improving IBS symptoms. Right. And then there comes this another study from Magnus Simran's group published last year. This is a single center, single blind RCT where patients, about 300 patients with IBS, were randomized to one of the three groups. The first group was the low FODMAP, which was also rooted in NICE or BDA principles. The second group was low carbohydrate diet, which was fiber optimized, and third was optimized medical therapy, where gastroenterologists were allowed to manage IBS medically as they normally do, right? As you can see here, even in adjusted week 4, both dietary interventions, low FODMAP in the red and low carbohydrate in the blue, did much better compared to optimized medical therapy. And if you can, the percentages are here, basically, again, a 10 to 15% gain in the responder percentage between optimized medical therapy and low FODMAP. So this study concluded that low FODMAP was actually better than optimized medical therapy. But remember, this was a feeding intervention. The food was provided to all participants in this study. And they concluded that low FODMAP could be used as first-line therapy for patients with IBS. So what these studies tell us, right? Like both these studies, the Jan Tak study, which I just showed, comparing it to antispasmodic, and Magnus Simran study, comparing it to optimized medical therapy, show that low FODMAP probably works for all IBS patients, primary care and tertiary care patients, right? It also tells us that it probably works almost as good as medical therapy, if not better, given the data is that maybe it is better than some of the medical therapies, such as antispasmodics, right? And even optimized medical therapy, although the food was provided here, right? So it does tell you that maybe low FODMAP is for all IBS patients as first-line therapy, right? And this is also reflected in ACG and AGA guidelines. Here is a picture of AGA guidelines on the left. And as you can see, I know it's hard to see, but you can see basically AGA places low FODMAP very upfront. All IBS patients, after establishing a provider-patient relationship and doing some basic lifestyle modification and reassurance, dietary modification, including fiber and low FODMAP, are very high before they even talk about pharmacological therapies, right? And same is with ACG. And of course, the ACG is on the right, where they do bring up more caution for eating disorder and psychiatric disorder and rooting in those specialties very upfront. If there is a concern for either of those, an active psychiatric disorder, which is hampering GI health, or a eating disorder, then maybe not go down the route of low FODMAP. Otherwise, they do bring it up very soon as well. Right. So again, we just talked about when to use it, but there is, as I just said, that right, the pendulum has switched to very extreme, in my opinion, right? Like 20 years back, there was no data on dietary therapies in IBS. Gastroenterologists were not using dietary therapies for IBS, and now everybody is on some or other form of elimination therapies, right? So we do have to find some middle ground here. And there are a lot of places where low FODMAP should not be used, in my opinion, right? Eating disorders, of course, right, including avoidant restrictive food intake disorders. These patients where there is a concern for an active eating disorder, a prior history of eating disorder or active ORFID, they should not place them on low FODMAP, right? If a patient is already on a restricted diet, that's not a patient I would want to put on a low FODMAP diet, right? Sometimes it's patient, we should talk to patients about their preference. Some patients are not in this space in their personal life that they can implement a low FODMAP diet, given how cumbersome that can be, right? And cost, of course, is important. Low FODMAP is more costly than habitual diet. So if a patient can't afford it, if you have a patient who's living on food stamps, then maybe it's not the best patient to talk to about low FODMAP, right? And when it comes to symptoms, I would say that if use it with caution if there is constipation and diarrhea are the main complaint. If there is not a lot of pain, not a lot of bloating, and it's a lot of constipation and a lot of diarrhea, then maybe use pharmacological therapies much more than low FODMAP in those cases, because low FODMAP doesn't seem to affect bowel habits as much as it does affect bloating and pain. Right. And a few words about ORFID. ORFID differs from other eating disorder than it does not involve any concerns for body shape or weight. DSM defines it as dietary restriction, which could be either reduced overall food intake or reduction in food variety that results in one or more of these four things, which could be a nutritional deficiency, a significant weight loss, or inability to gain weight, dependence on supplemental nutrition, either tube feeds and hopefully not parenteral nutrition, and impairment in psychosocial functioning. If you have a dietary restriction which leads to one or more of these things, then you would qualify as ORFID, right? And studies have shown that about 20 to 25% of patients with IBS and other DGBIs likely have ORFID. At tertiary care centers like where I am, that percentage is even higher as 40%, right? So I strongly believe that a gastroenterologist must screen our patients for ORFID and other eating disorder before introducing elimination diet and before handing them out a sheet of elimination diet or low FODMAP, right? I do it in my practice by just asking some open-ended questions, which I find very helpful. Just simple open-ended questions like, how is your relationship with meals, right? Which they can fill in with however detail they want. How is your appetite in general? How's your weight doing? And if they have lost like 30 pounds in the last 6 months, then maybe not talk about low FODMAP there, right? And things they like to eat and things they avoid to eat. They can give you a lot of information in just a few of these questions. Of course, there are more specific questions like SCOFF, NIAS, and EDEQ, which can screen for these eating disorders, including ORFID. However, their sensitivity and specificity in diagnosing ORFID and in patients with DGBI remains unclear, given the huge overlap between that symptoms and the DGBI symptoms, especially of dyspepsia. So how to use it, right? And again, I think one thing I want to get it off of the bat is like, of course, the answer is with a dietitian. Don't try to do it yourself. Don't try to do it just with a sheet. It is not ideal and it almost certainly will fail, right? And the reason why is, again, like dietitians, you guys know this, right? Like, but for gastroenterologists and other practitioners and patients, right, they don't know how much you can add, right? And this is a beautiful study from Caroline Tuck published 5 years back now, showing that in 80 patients who underwent actually low FODMAP, they found that the patients who saw a dietitian achieved a lower mean FODMAP intake, as shown in figure B here, and met more of the patients who saw a dietitian met the threshold of FODMAP less than 12 gram intake per day compared to those who did not see dietitians. So that's one thing. They are more compliant with the elimination phase because they have more information, they have more knowledge, right? And the second part I think is more important. That if you see a dietitian, you are much more likely to move on to the phase 2 and phase 3 of reintroduction and maintenance. So the patients who saw dietitians were more likely to complete all three stages of flow FODMAP compared to those who did not see a dietitian. That I think is so important, so immensely important, that in my mind is enough of a reason in itself to see a dietitian and work with a dietitian to do a low FODMAP. Of course, there are other reasons, as I mentioned, it's a very complicated diet. It's a very cumbersome diet. You can get lost very quickly. You can have side effects such as weight loss. So all the reasons to work with the dietitians, right? And the second part is obviously we have to talk about patient experience, right? So obviously the way we do low FODMAP is a step down approach, which we just talked about, going from restriction to reintroduction and to personalization. And this is some of the data where we, with help of IFFGD, surveyed IBS patients in community. I think there is about 120 patients in there. And as you can see, this is the data from their experience. About 70% of patients with IBS who did low FODMAP, the step down approach, found that was somewhat or extremely difficult, right? Again, coming down to whether they found it restrictive, again, another 80 or 90% of them found it somewhat moderately or extremely restrictive. That's a lot of patients finding it very restrictive, right? And reintroduction phase was no better. 50% of the patients thought that even reintroduction phase was somewhat or extremely difficult. So overall, patients had a lot of difficulty, lot of restriction, and very less satisfied with these phases of low FODMAP, right? And look at this data from the same cohort, time spent on restriction phase. The guidelines recommended for 8 weeks or less, right? And only less than 40% of the patients did that. 60% of the patients did it longer than 8 weeks. There is about 1/5 of the patient who kept going on elimination phase for more than 20 weeks. And time spent to complete reintroduction phase was also very long, in my opinion, like more than 20 weeks for about 1/5 of the patients, right? And as you can see again here, about half of our patients don't go on to the personalization phase of low FODMAP, even though it was effective for them. And about those who go on to personalization phase, about half of them avoid 10 or more food items, right? So there is a lot of issues with the way low FODMAP is currently practiced. It's restrictive, it's cumbersome, it's time consuming. It takes months to complete all three stages, even if you do them on time. And clearly, I just showed you a lot of patients take even longer. It's costly. There is a definite risk that patients can continue elimination phase very long term and putting themselves at risk of micronutrient deficiencies and dysbiosis, right? So to simplify this regimen of how low FODMAP is practiced, because in my mind, a lot of this is not a problem of low FODMAP, is how it's practiced right now, right? So we and others have tried to figure out, is there a way of simplifying this, right? And the first step is to identify, are there FODMAP subgroups which are more likely to trigger symptoms compared to others, right? So this is work done by Yantek's group again. They took patients with IBS who responded to low FODMAP, challenged them in a double-blinded fashion with one FODMAP group at a time, hiding it in a drink, and monitored symptom response. And what found was that among all the FODMAP groups, fructans here and mannitol were the most likely to cause worsening of IBS symptoms. Of course, I want to point out that the mannitol dose used here is 15 grams, which is about 15 grams higher than the mannitol being consumed by IBS patients on a daily basis. So that's a very high dose of mannitol, right? And then we did a similar study, exactly same principle, patients who responded to low FODMAP. They went on a double-blind food challenge where we hid one of the FODMAPs in a cookie and gave them a cookie for 7 days. And again, we found the very similar findings. Fructans, again, were very likely to worsen abdominal pain and bloating in our cohort. And what we also found was that GOS or galacto-oligosaccharides worsened bloating in our study. So based on these two reintroduction studies, we designed a FODMAP simple diet. And I think I presented this data before at DDW and published them last year in CGH, where we defined FODMAP simple as a diet which would eliminate only fructans and galacto-oligosaccharides, but would allow polyols, would allow lactose, would allow fructose, and compare that to a traditional elimination phase of low FODMAP. And this was a pilot feasibility trial comparing these two diets in IBS-D patients. And this was a small study of only 30 subjects. And here, because this was proof of principle, this was a feeding intervention. We gave them the food. And as you can see, the primary endpoint was improvement in abdominal pain intensity, defined by FDA as 30%. So proportion of patients who had 30% improvement in their pain in both groups was around 60% and was not very different. And coming to IBSS, as I've told before, 50 point is kind of the hallmark of improvement, and some people consider 100 points. And for both of those endpoints, the exact same percentage of patients actually responded to in both groups, right? So the FODMAP simple clearly worked for most of the patients and was appeared to be very comparable to the traditional low FODMAP, right? And the good thing was it was much better tolerated than traditional low FODMAP. The adverse event rate in the traditional arm was 26.3%, and in the FODMAP simple was 12.5%. Sorry, the numbers are switched here, but the adverse event rate again in traditional arm was 26%, and in FODMAP simple was 12%. So not only it was as effective as traditional low FODMAP, it was also much better tolerated. Of course, this is a very small sample size and needs to be validated in much larger studies, which we are working on. But if it is proven, maybe we can change the paradigm on how we currently apply the low FODMAP, which is a step down approach where you go from restricting everything and then refining it to a step up approach where you go from FODMAP simple, see if patients respond. If they respond, that's great. If they don't respond, then only you can restrict further, right? So changing it to a step up approach, and hopefully we can get there. Coming to the next objective. So I think we have answered why use it, when use it, and how to use it. Obviously, the answer to how to use it is with a dietitian, and then obviously more data needs to be there for a step-up approach, but maybe a step-up approach in future if it gets us the same result as step down. And the next question is, how does it work? Right. And to answer that, I think I'll present you one of our studies. It's a beautiful study which we just finished, is where we took patients with IBS-D and put them on a low FODMAP diet for a period of 4 weeks and measured their barrier function and before and after. We did a flexible sigmoidoscopy, got biopsies from them, did a lactulose mannitol assay, which is again a marker of how leaky your gut is or how much your barrier is disrupted in the gut, and measure them before the low FODMAP and after the low FODMAP. In our study, we had about 80% of the patients responded and the 20% did not. And this is just their data. But coming to the barrier function data, you can see in patients with IBS-D, when we put them on a low FODMAP, their barrier function actually significantly improved. The mannitol excretion, which is a marker of barrier function, got significantly lower excretion, which means that their barrier was more stronger. So the mannitol could not get from the gut to the blood, right? TR, which is a marker of resistance, is also got significantly better after low FODMAP. This means that the mucosa again had much more barrier integrity after the low FODMAP. This is data on their tight junction proteins at RNA and protein levels, again showing the same thing, that the amount of expression of these tight junction proteins after 4 weeks of low FODMAP was significantly better. This is one of the tight junction protein, Claudin-1. And again, I don't think you need to be a scientist to know that the expression of Claudin-1 before the low FODMAP is much lower compared to its expression after, which you can see here in the white highlighted staining, right? Again, showing the same thing, the tight junction integrity and the structure was much better after the low FODMAP diet. Other thing we did is we counted the number of mast cells in these biopsies, and we found that before low FODMAP, there were a lot of mast cells in the colon of these patients, and after the low FODMAP, the number of the mast cells significantly reduced, as you can see with this green staining from the same patients before and after. And when we measured the mast cell activation profile, that is these substances like tryptase, prostaglandins, and histamines, which mast cells release, we measured them before and after low FODMAP. And as you can see here beautifully, after the low FODMAP, the levels of all these mast cell products were significantly lower in these patients. So these two studies, these two data points tell us that their barrier function actually gets better, and their mast cell number and activation profile also actually gets better after the low FODMAP diet. So taken together, I think we did more of the experiments here where we showed that the fecal LPS, which is a cell wall product of the gram-negative bacteria, or a dysbiosis index, was significantly lower after the low FODMAP. And then I don't want to get into the weeds of these mice experiments we did here, but the summary of those experiments were that if you either remove mast cells from the picture or remove LPS from the picture, you don't get that barrier dysfunction related to FODMAP. So what's happening here is that in IBS patients, they have a dysbiosis which is fueled by FODMAPs, which leads to increased LPS. The LPS gets in, it activates the TLR4 receptor on the mast cell. Mast cell dumps all these bioactive molecules like prostaglandins, histamines, and tryptase, which kind of disrupts the barrier by eating away the barrier. Right. And what happens after the low FODMAP diet is it decreases the LPS level. So the LPS is not there to activate the mast cells. There is less mast cell activation. There is less mast cell recruitment. So mast cell is not releasing all these products, and therefore the barrier is not disrupted, and barrier is more strengthened after the low FODMAP diet. So again, we've shown you that just the theory that FODMAPs work by osmotic effect is definitely true. Like, it definitely reduces the osmotic load in the colon, but it is much more complicated story. Here we just wanted to show you guys a glimpse that it has a lot more physiological effect than osmotic effects. It can strengthen your barrier, it can improve your mast cell activation profile, and also the other data we have that it improves visceral hypersensitivity in these patients as well. So it kind of it fixes the underlying problem here, right? So coming to the last piece of data, who should we use it in, right? Again, by that I mean, is there a biomarker for low FODMAP? And the short answer is no. Right now, there isn't, right? There is obviously a lot of microbiome studies that have been done. I'll highlight one of these published a few years back, where they took patients with IBS and healthy controls and charted their microbiome. And they found that IBS patients had two different kinds of microbiome. One was the dysbiotic microbiome, which was highlighted again in red. And then one was the healthy microbiome, which was similar to healthy controls here in the gray. And when they put all IBS patients on low FODMAP, look what happened. The patients who had dysbiotic microbiome, they moved more towards healthy control. And the patients who had healthy microbiome, they did not move their microbiome much towards health because they were already there, right? So it kind of tells you that in this group which had a dysbiotic microbiome, a low FODMAP kind of fixed that dysbiosis. And more surprisingly, that correlated very well with response. That patients who had dysbiotic microbiome were more likely to respond compared to those patients who had a healthy microbiome. So overall, from our studies, and these studies show that low FODMAP can fix dysbiosis in some patients and can obviously in short term, right, and can strengthen your barrier and improve mast cell profile as well. Until biomarkers are available, I would say rely on your clinical judgment. If you have a patient with IBS where irrespective of what subtype they have, if they have a lot of pain and a lot of bloating, then maybe you can try low FODMAP. Of course, they have to be motivated to try it, and there is no red flags there. They're not losing a lot of weight. They're not already on a restricted diet. And there is some data that if you have higher symptom severity, you're more likely to respond as well. Okay, enough about low FODMAP, going to other dietary therapies, right? Of course, the first one is nice diet. You guys know a lot about nice diet. It's basically a eating style where you change your meal timing to make sure you consume regular meals at regular interval, sit down to eat, avoid skipping meals, avoid eating late at night, drink enough fluids, increasing fiber, especially soluble fibers in terms of oats, and limit spicy food, limit fatty food, and so on. So this is just basically a eating concept, which I just refer to as house cleaning, and I think it has a place, right? Although no RCT has compared it directly with sham dietary interventions in IBS. And a recent meta-analysis has showed you did not find that NICE guidelines were superior to any other alternative or controlled diet. It does have a place in my mind. It is very easy to implement for patients. Patients like it for that. Individual trials do show that 40% of patients can respond to a nice diet. Some of it might be its placebo effect, but some of it might just be the house cleaning effect, which I'm talking about, right? Where patients are eating just whatever they want, and getting them into a structure and a routine is just what they need. It definitely is more acceptable to patients, and that obviously has a lot of value. Right. Coming to gluten-free diet, there is not very high quality data on gluten-free diet in IBS. There are some randomized controlled trial which shows that gluten-free diet maybe can reduce global IBS symptoms compared to controlled diet, but the data, as I said, is not high quality. This is a CGH study on the right where they compared the traditional dietary advice or the NICE diet with low FODMAP and gluten-free diet, and found that all three diet worked similarly. Of course, they were not powered for to study efficacy. And as I've said, meta-analysis have shown that low FODMAP has better efficacy than TDA, but that is not true for gluten-free diet. We don't know if it works as well as low FODMAP or not. And of course, a lot of effect of gluten-free is coming from reducing fructans, wheat being the most important component of fructans in Western diet. But this study did find that that TD, as I was saying, the traditional dietary advice was more acceptable compared to either gluten-free or low FODMAP diet. Coming to Mediterranean diet, there have been two RCTs now on Mediterranean diet in IBS. One was published a couple of years back by Heidi, where they compared Mediterranean diet with habitual diet and found that a Mediterranean diet worked much better compared to habitual diet in patients with IBS. But of course, their patients were on a habitual diet in one arm, so it was not blinded, and there was no active comparator arm. And IBS being IBS with a huge placebo response is a major limitation of this study. But at least it showed us that Mediterranean diet is feasible in patients with IBS, and it was very well tolerated. On the heels of that, we did our study where we compared Mediterranean diet with low FODMAP in patients with IBS D and M. Again, there is a small study with 22 subjects, and we found that Mediterranean diet did improve abdominal symptoms of pain, bloating, and discomfort in more than 50% of the patients with IBS D and M. But it did appear, looking at global endpoints, that low FODMAP did a little better than Mediterranean diet in improving global IBS symptoms. Although I would say that another caveat of this study is that this is comparing elimination phase of low FODMAP with Mediterranean diet, right? And Mediterranean diet is a long-term diet, while elimination phase of low FODMAP is not meant to be long-term. And at some point, you're going to reintroduce and going to personalize. And of course, there is no data by any study so far comparing the personalized phase of low FODMAP with Mediterranean diet, which would be a more fair comparison looking at 6 or 12-month data. But of course, those studies are very hard to do given logistical challenges. But I would say that based on these two studies, it does appear that Mediterranean diet is feasible. It's very well tolerated by our patients, especially with some minor modifications. And then it does have a role in some patients, especially those who are not eligible for low FODMAP. There is IgG-based diets as well. Those diets have been discussed in the past, and that obviously offers a promising approach because it's a much more focused elimination compared to this blanket elimination from low FODMAP. However, existing studies have a lot of limitations. They're open label, they lack a sham or control arm, they're single center, they have small sample size, and most importantly, generally, there is no scientific rationale of why a food was included in an IgG assay, right? And you can normally, I cannot stress this point enough, even healthy controls have IgG responses to food. That's normal. So just because you have IgG response to a food doesn't mean that that food is causing a problem in you, right? And it is because of these methodological problems with these studies that AGA or ACG does not recommend using IgG-based testing in IBS. But we just finished a study and we'll show you the data. This is a novel discriminatory IBS-specific IgG assay where we started with 90 commonly consumed food and drilled it down to 50 foods first and then 18 foods in the final assay. And the way we selected these foods were these foods separated IBS patients from healthy controls. These were the foods where the IgG response of IBS patients were very different from healthy controls. And so we used that to select the patients, right? And if you use this assay based on that, we did a multi-center 8-week sham control double-blind RCT where the primary endpoint was, I've discussed before, FDA definition for abdominal pain responder in IBS. And the data is shown here on the top. The study is going to come out in Gastro next month. But if you look at the experimental IgG-based elimination diet, about 60% of the patient responded to that compared to 42% in the sham diet. And this was statistically significant, meaning the study met its primary endpoint, right? And if you look at individual IBS subtypes, I think it's very fascinating because although we were not powered for individual IBS subtypes, if you look at IBS C and D, that's where all the action is happening. That's where the huge delta between IBS C and IBS M showing a much higher responder percentages with IgG-based diet compared to sham diet. And if you look at IBS-D, there is really no signal that it was working for IBS-D patients, right? So again, I think obviously it needs to be validated in a larger study subjects, but this was over 200 subjects. So it's a pretty decent sized study showing that maybe a IBS-specific IgG-based elimination diet can work for our patients with IBS-C and M. I think it's great for our patients, especially for patients with IBS-M, where there is actually no FDA-approved pharmacological therapy. If it does pan out, it will be very helpful for our patients. And of course, there is leukocyte activation testing, which in a single center double-blind study has been shown to improve symptoms as well compared to sham diet. They did test over 200 foods, though. So I think those were some of the new diets which have been recently studied in IBS. And let's talk about fiber and functional foods, because I do want to leave plenty of time for questions. So coming to fiber in IBS, right, I think this is a meta-analysis published a while back now, which suggests that soluble but not insoluble fiber does improve global IBS symptoms, as you can look at this forest plot here. And based on these meta-analysis and multiple individual studies, both American College of Gastroenterology as well as AGA recommends use of soluble fiber for global symptom improvement in IBS, right? And coming to functional foods in IBS, first is I wanted to discuss was kiwi. This is another RCT done from our center, Bill Chase group with us, where we compared kiwi with prunes and psyllium in a 3-arm parallel group RCT in patients with functional constipation, where we found that kiwi can significantly improve stool frequency, stool consistency, and abdominal pain, actually, right? So it does seem to improve stool symptoms as well as some of the pain symptoms. As you can see in these graphs here, it might be slightly less effective than prunes or psyllium in improving stool consistency, but it does appear that it's much better tolerated than either of them, prune or psyllium, especially prunes. It is much better tolerated. So I think that definitely is a plus point there. Sorry, I did want to highlight, you can see that here in any adverse event was obviously lowest for kiwi here and compared to psyllium and prunes where they had much higher adverse events compared to kiwi. So kiwi does appear to be better. And of course, bloating is significantly worse with prunes compared to kiwi in our patient population. So coming to prunes, prune also have some data behind it, right? Because they are laxative. They in itself have polyols, prunes in doses of 80 to 120 grams per day. About 100 grams is about 12 prune have been shown to improve stool frequency and stool weight to a greater degree than either placebo or psyllium. They've been mainly studied in functional constipation, not in IBS constipation. But I think for relieving stool symptoms, it probably will work as well for IBS patient with constipation. Although we have to be aware of these side effects of prunes I just talked about, like bloating and pain, which it does tend to be more with prunes. It is probably is more effective for mild to moderate constipation patients compared to the more severe constipation patients, where we might have to rely on pharmacological therapies. Coming to aloe, berbeloin is one of the major components in aloe vera, which plays a critical role as a laxative. There are not a lot of good studies on aloe. There are just 3 small studies with a total sample size of around 150. So, obviously a lot more data is needed, but it does appear that it improves pain and bowel satisfaction in this study. And the dose studied is around 100 to 200 ml daily for aloe in these studies. Coming to probiotics and prebiotics, I think recent guidelines by both ACG and AGA either recommend against or make no recommendation for probiotics for treatment in IBS. And a lot of it comes from basically there are not a lot of high quality studies for probiotics in IBS, right? The studies they are there don't have stringent endpoints. They don't even go on up to 12 weeks. They're either single center, so they don't have a lot of methodological problems. And that's why there is no guidelines supporting the use of probiotic. It's not that they don't work. The bottom line is we just don't have enough data to support. And similarly, for prebiotics, there is very limited data, and it's very unclear if it actually benefits patients with IBS. So coming to summary, low FODMAP is the most evidence-based diet in IBS. And the symptoms of IBS, it most likely improves are abdominal pain and bloating compared to bowel habits, which it has less effect on. I would say that, as I said before, we can use it in all IBS subtypes, IBS D, C, and M. It could be considered as first-line therapy in IBS. It could be considered in patients with presenting to primary care with IBS, or to GI, or to dietitians. Of course, there is some data that its efficacy might even match medical therapy, but that has to be looked into in more multi-center trials in the United States, which it hasn't been looked at so far. I would caution and screen for eating disorder and ORFID in our patient population with DGBI before initiating a conversation around low FODMAP because of the reasons I've discussed before. Coming to how it works, I would say the simplistic view of low FODMAP working via reduction in osmotic effect alone is likely not true. It directly, as I've shown you the data, I think directly targets IBS pathophysiology by improving dysbiosis and fecal LPS, mast cell recruitment and activation, barrier dysfunction, and even visceral hypersensitivity based on other groups' work. A FODMAP simple diet does offer a promising alternative step-up approach to implementing low FODMAP. Obviously, that needs to be validated in larger, adequately powered studies. And hopefully, there are alternative dietary therapies, such as individualized approach to an elimination diet based on IgG, or IgG, which is specific to IBS, or leukocyte activation test, or alternative approaches such as Mediterranean diet. But for all of these diets, FODMAP simple, Mediterranean diet, IBS-specific IgG, or leukocyte activation test, we just need larger, adequately powered studies. Soluble fiber should be used and should be considered for global IBS management. I do feel that in the day and age of low FODMAP, that fiber I can't stress enough, like we should go for fiber first. Like I feel like a lot of times my patients have jumped the hoop and go to the low FODMAP and have made no changes to their dietary fiber intake. And I bet if you calculate their dietary fiber, it's not more than 5 grams a day. So soluble fiber does work for IBS, and I think has a great role, and is very underutilized, especially at tertiary care centers. So we can all do better there. Functional food can also be used for managing GI symptoms in IBS. Of course, more data is needed, but I shared that there is some data to support kiwi, aloe, and prunes in this patient population. Available data on dietary supplements, probiotics, prebiotics, and digestive enzymes. And again, I'm not talking about FODzyme. My scope did not cover FODzyme today because of the objectives laid out, but digestive enzymes such as amylase, lipase, their use is not supported in IBS patients, given there is no data, which is different from FODzyme, where we have in vitro data. And we will, of course, I'm excited to say we will share some IBS patient data, this DDW. So we were very excited for that as well. Thank you.
Wonderful. Thank you, Prashant. That was incredible. We've got some really great questions here. There's a number on the IgG test. So let's start with one of those. The question here is, what foods came up most commonly, or were they varied among patients? The attendee is curious if the foods that were eaten were those that were already likely to cause an issue, like gluten containing foods, lactose, or high fructan. We also had just a couple of other questions around like how the test works. So if you want to maybe cover those two at once, that'd be great.
Okay. Yeah, so this is a IBS specific IgG assay. And I can, if people are interested, I can give you the details of the company which makes it, which I have no financial interest or disclosure to share, except that obviously we authored the paper. Is that the foods which did came out most commonly associated in that test were, I think for our patients with IBS, was wheat. Wheat obviously came out first, and then egg was there, if I remember correctly. So I think it was wheat and egg were the top two, if I remember correctly, and cow's milk was the other one. So they were the most common food people with IBS tested positive for. So these three, and of course, cow's milk and wheat, you can imagine, have a huge overlap with FODMAPs, and wheat itself. We have covered this before. It's a complicated food in itself. There is gluten in it. There is fructan in it. There is amylase inhibitor in it. So wheat is just a very challenging food, but I would say, like, to share it all, right? Like wheat comes everywhere. Wheat comes whether you do a CLE based study, whether you do a IgG based study, you do a FODMAP and FODMAP simple based study. Wheat is always there. So, I think yes, there is obviously huge overlaps there, but it does say that the food which were selected there were just specific to wheat. Like we were not restricting onion or garlic there. It was just wheat and no other source of fructan, despite that overlap. But there were other foods there which were not high in FODMAPs, such as I forget what else is there, but there are some fruits in there which are not high in FODMAPs, and some nuts there as well.
Thank you. Great. That's really helpful. Here, moving on to the Mediterranean diet, we have a question. Is there evidence of certain foods or food patterns eaten while comparing the Mediterranean versus a FODMAP elimination diet? Or do we know any of the mechanisms for the efficacy behind the Mediterranean diet?
Sorry, comparing Mediterranean with what was the question?
Low FODMAP.
Yeah, so I shared my slide, hopefully. So the only study which has done that is our work, and I'll just go back to my slide. If it's easier, hopefully. Maybe not. I can't go back. But here is this slide I showed you with. This is our work comparing Mediterranean diet with low FODMAP, where you can see this is the head-to-head comparison of Mediterranean and low FODMAP, and the endpoint was proportion of patients with improvement in abdominal pain and Mediterranean diet had 72% patients improvement, with low FODMAP at 81%. But when you look at more global endpoints, just adequate relief for IBSS, um, uh, again, about 40% of patients did improve, even for Mediterranean diet, but low FODMAP just did a little better at about 50 to 80%. So, yes, I feel like the summary is yes, it has been compared. The data does suggest that low FODMAP might actually um, um, turn out to be better than Mediterranean, at least in its restriction phase. But as I've said before during my talk, like I think you have to remember restriction phase is only going to last you 6 weeks. You're going to eventually go to personalization phase, and there is no study right now comparing the personalized phase of low FODMAP with Mediterranean diet. Given Mediterranean diet, you can just continue forever. Right. So
Thank you.
that study needs to be done.
Got it. Here we did have a couple questions here around the low carb diet. So what was kind of the definition of low carb or the range of carbohydrates used?
Yeah, I think it was very, very stringent. Like I think it was 10% of the total body energy intake was coming from carbohydrate. I actually have the paper. I can I can pull it up and quote and look at that directly. But I think it was very, very restrictive. So when I saw that, I wasn't sure like how patients were going to do it, but that's why I was highlighting it was a feeding intervention. So they actually gave the food. So that's how they were probably able to achieve it. But it was much lower than even what other people think of low carbohydrate diet. They did optimize it for fiber by including things like nuts in there. Um, uh, 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 but otherwise, it was pretty low.
Great.
And a lot of energy was coming, obviously, from proteins and fat.
Here we have a question from Sanjita. What could be the reason for patients responding to a gluten-free diet? Could it be because they're low fructan automatically from the grain production?
Yeah, absolutely. Meaning people have done studies, right? Like where patients with IBS who consider themselves as gluten sensitive, they go on a challenge diet where they are challenged with fructan or gluten itself while continuing the gluten-free diet. And and when they don't know it, that is, they're blinded, the symptoms were almost uniformly positive for fructans or inulin compared to gluten itself. So it does appear that it's the fructan which drives most of the symptoms in the symptom improvement in the gluten-free diet. But of course, there might be some immunogenicity from gluten or ATI related things which it is doing. There is some data that if you have anti-gliadin antibodies in the blood, not the TTG, but anti-gliadin antibodies, then you are more likely to respond to GFD, and maybe those are the patients where gluten is playing more of an immunogenic role. But just a thought. There's nothing to prove that.
Great. More research is needed as usual.
Yes, sure.
Here, another common theme that's coming up we're seeing is around the low FODMAP simple diet. This question is, are there a list of foods that are acceptable? A few others are asking about foods that you would be eliminating. So maybe if you could just give us an overview of what that might look like, practically speaking.
Yeah. So so we have started at Michigan Medicine's implementing or offering it in clinical practice in obviously talking to patients about FODMAP simple if they don't want to do low FODMAP because they're like just overwhelmed with it. Or some patients are like, they just automatically ask, is there just a simpler way of doing this? Because I can't do that again. I tried that 5 years back. So what we start with is restricting fructans and galacto-oligosaccharides, right? And fructans, obviously, the biggest culprits of fructan in Western cuisine is wheat. Wheat, and when I say wheat, I also mean rye and barley, but wheat, rye, barley, and onion and garlic, right? So we take these things out. The fructan is taken care of, and of course there are other sources of fructans, but these are the big ones. And GOS, of course, as you guys know, are legumes are the big ones, right? Most of the legumes, red beans, black beans, fava beans, and chickpeas in a certain quantity and so on are high in GOS. So GOS comes from there. So I would restrict that too. So targeting fructans and GOS rather than targeting fructose, polyols, or lactose.
Thank you. Great. And while we're on this topic, we do have a couple other questions just about the difference between a FODMAP simple and a FODMAP gentle. So if you want to clarify that, that might be helpful for everyone.
Yeah, that's great question. So I would say the main difference between how and what we designed as FODMAP Simple from FODMAP Gentle is FODMAP Gentle is not evidence-based, right? FODMAP Gentle is basically if you find a food which is a trigger for you, eliminate that if it happens to be high FODMAP, basically, right? Like if you find a food, oh, every time I eat beans, I get bloated, then of course eliminate beans, right? And bean happens to be high FODMAP, where so there is no more, it's not more targeted than that, other than patient has to link that. But FODMAP simple is just another way of approaching low FODMAP, where you are eliminating two groups of FODMAPs, both fructans and galactans, and seeing and going from there. Like I would see that as a starting point to a step-up approach if you respond to that, or even if you didn't respond to that, because you can go more. And of course, there is science behind it, because we have found that fructans and galactans are the FODMAP groups most likely to cause symptoms in our patients. And then there is science that FODMAP simple actually might be comparable to traditional low FODMAP in terms of efficacy, and definitely better tolerated by patients.
Thank you. Great. Here, moving on a little bit to soluble fiber. This question in particular is, how long do you tell a patient to be consistent with soluble fiber before being able to see results in their IBS symptoms?
Yeah, I definitely tell them, like, if like obviously you have to get them there. So it's sometimes it is like a process just to get them to the goal of soluble fiber. You need, like, for example, of a psyllium husk, I want them to get to 2 tablespoons or 1.5 tablespoons, right? And given our patients are so hypersensitive, I'm starting them at 1 teaspoon, and then I'm like, okay, go do that for a week, and then go to 2 teaspoons, then wait a week or 10 days, then do 3 teaspoons, right? And if they are seeing, if you have reached 1 tablespoon, I will say keep that for like 4 to 6 weeks before you tell me whether you're noticing benefit or not, right? Like, so I think first is take them slow so that you can reach the targeted goal, whatever you have in mind. And then second, if you're reaching there, just maintain it for another 6 to 8 weeks before you say that it's working or it's not working.
Thank you. And continuing kind of on that theme, but moving a little bit into eating disorders as well. Given that patients with eating disorders are not appropriate for a low FODMAP diet or other elimination diets, does that mean it's more emphasis on the fiber, the functional foods, medical management? How should they be thinking about that?
Yeah, absolutely. You're right. Like, I think you're absolutely on the track, right? Like, if you have a patient with ORFID or eating disorder, first, like, I would say engage behavioral therapies whenever you can, to kind of help them overcome some of this fear and anxiety around food. And then doing more of medical management till they are ready for any kind of dietary therapies, right? And and try to liberalize their diet however we can, while working with functional foods, even Mediterranean diet, because that's not an elimination diet, and works very well, as we know. So that's something we try a lot for our patients with ORFID, is Mediterranean diet, because again, if they can do some version of Mediterranean diet, that's great.
Great, thank you. Here we have a question just around some clarification regarding the indications for low FODMAP and the specific symptoms. This question is just looking for clarity around low FODMAP diet with patients with constipation, and how they should be, thinking about a low FODMAP diet if there is no diagnosis.
Yeah. So I would say that's a great question, right? I think I'm guessing the worry there is low FODMAP will reduce fiber intake and that constipation gets worse, right? Like, I think, I'm guessing that is, they can respond if that is what they're targeting to. But there is a place for low FODMAP in constipated patients as well, right? I think there is data that low FODMAP works great for patients with IBS with constipation as well. What IBS means is that they have pain and bloating as their predominant symptoms, right? So some of this pain and bloating comes from constipation, and the first step is obviously to manage constipation. And if they're still bloated and have pain, I try low FODMAP in my clinical practice. So I target the constipation or the hard stools first, with pharmacological therapy or fiber or dietary supplements or functional foods if I need to, and then go on to do low FODMAP if pain and bloating persist. If there is a patient who, let's say, has no pain, no bloating, and is pooping once a week, that is not a patient I will try low FODMAP on because it does not change their bowel habits.
Thank you. Great. Here we have a question looking for some clarity or insight into why we might think that patients are staying on an extended elimination phase and not advancing their diets.
Yeah. That's such an awesome question, right? Like I feel like it is a jigsaw puzzle, and has multiple reasons. First is some of our patients are not working with the dietitian. Remember, they are working with GIs who just gave them a sheet and told them this is what a low FODMAP diet is. Just don't eat these food, eat these food, and never talk to them again. And the next follow-up is in 6 months. Right. So for the 6 month, they're going to just do that thing without knowing what the next step is. So that's why please see a dietitian who knows what a low FODMAP diet is and work with them. Don't do this alone. Second, I think even if they work with a dietitian, sometimes our patients have been suffering for a long time and low FODMAP works for them, right? Like they work and they are very afraid of reintroducing because they are like, I don't want to feel crappy again. I just got my life back. I'm feeling great. Um, I don't want to reintroduce. So there is that fear of reintroduction. And second, I feel like reintroduction is a maze. Like I would not last 2 days in reintroduction. Like you gotta start with one food, and then like for 2 days you do this, and then you increase the dose, and then monitor symptom response. And if you react badly, you're like, I'm not doing this. I go back to my elimination phase, and then go back to the restriction reset, and never tried reintroduction again. So a lot of this is that, right? Reintroduction is not easy. There are 5 groups and different doses in each 5 groups. So it's a lot of work on patient's part.
Thank you. Great. Yes, very much a complex one. I'm seeing a couple questions here about our FODZyme clinical data. Just to clarify that for everyone, we've presented some abstracts at previous conferences. We're presenting more this year, so more clinical data to come. To date, a lot of our work has been in vitro, looking at FODZyme in a simulated digestive tract and its efficacy breaking down fructan in a simulated model of the digestive tract. So just moving on.
Yeah, and where, by the way, like I think I can, meaning I again have no COI, right? So I can say that in the that work which we did with FODZyme in vitro shows very beautifully that it is able to digest fructans into the fructose, which is what it's supposed to do, right? Is the first thing, and then second, that if you can clearly see these beautiful simulation that the fructose level goes up into the small intestine but doesn't increase in blood, which is great. And the third thing is that there is less gas and less and more short chain fatty acid production when you use FODZyme with fructans, compared to rice. So there is less gas, so therefore there will be less bloating and pain, meaning that it probably will achieve the things it needs to achieve in vivo there.
Thank you. Great. We were really privileged to partner with their team on that early research and continue to go on with more clinical data as well. Here, I will ask our last question here on a hopefully optimistic note. When some people go through a low FODMAP diet, are they ever able to tolerate the foods again? I think is what we're trying to get at here. So more or less, how do FODMAP tolerances evolve, and what are some of the factors maybe driving that?
So is it like how people get more or less tolerant of FODMAPs over time?
Yeah,
Is
I
that the
think that's the
question?
question. So were people who went through a low FODMAP diet ever able to tolerate the high FODMAP foods again?
Yeah, I mean, I think I would start by saying that remember both Jan Tak's reintroduction study and our reintroduction study shows that a vast majority of IBS patients are only sensitive to 2 FODMAP groups and not more. So they're already like, it could be any of the two, and most likely it's fructans with something, but generally, generally speaking, you're not sensitive to all 5. So you can already reintroduce the 3 or 2 you're not sensitive to. And the ones you are sensitive to, right, I would say if some of it is being guided by visceral hypersensitivity, some of it is that, let's say fructans, for example, make gas, right? And if you can manage the visceral hypersensitivity, or for example, if you're taking FODZyme and you can decrease the gas production in the colon, then you can tolerate that fructan group much better. Right, so there are ways to go around it, is what I'm trying to say. Some of it is not being able to tolerate is because your gut is very sensitive, and neuromodulation can help there, or behavioral therapies can help there to kind of decrease that visceral hypersensitivity to these food. And second is modifying how you eat food, right? Like if you can't eat wheat, you can eat sourdough, like slowly leavened sourdough. That would be one way where the fructan is lost, but you still have the gluten, or using it with supplemental enzymes such as FODZymes, where there is data, right, that it will allow you to consume that, would be another way of looking at it.
Wonderful. Well, thank you for truly an amazing presentation.